So, good evening, friends. Welcome to this INICET May 2024 recall session, and we would be dealing with the ophthal part. So, before I start the session, I would be basically telling you that this is the first time we have got so many questions of ophthalmology after so many years. But the problem was that we were not very much prepared to get around 11 to 12 questions. The best thing about the ophthalmology is that whatever the questions were asked, almost 100% of the questions were being covered in our app and in our notes. So when we start our discussion, I would be just showing you the snapshots, the snippets of our notes as well as the videos, so that you can have an idea that how basically to go forward. If you have any doubts, you can put it in the comment section, and it would be a very fast and crisp session. If you basically have any doubts in ophthalmology, just basically put it in the comment section, and you can basically log into our Manipal MedAce app, and we are always there for you. So without wasting too much of our time, we are going straight forward to basically discussing whatever the questions are asked and how to basically cover these topics. Please remember that when you are going to go for the NEET 2024 session, you expect a lot of ophthal questions, because in the next guidelines which they have basically given earlier, they have basically told ophthal as a major subject. So might not be the next is there this year, but very important is that you would get more questions from the your ENT and ophthal. Okay, so let us start our session, and this was our first question. This question was: a patient was having some cardiac issues. Some students say that it was written atrial fibrillation. Some students were saying that it was basically written rheumatoid heart disease, and presented with the superior field loss. Okay, so the patient is having a superior field loss. So which of the following is the most probable cause of this condition? So your options were branch retinal artery occlusion, central retinal artery occlusion, central retinal vein occlusion, as well as branch retinal vein occlusion. So here, okay, Rishikesh, there is a history of 1 week loss. Okay, fair enough. So here, what you have to basically see is that they have given there was a superior field loss. Do you all agree? There was a superior field loss. And what would be the answer here? The answer here would be branch retinal artery occlusion. Okay, so what are the important points through which you can get the answer? So first of all, remember what I have basically told you again and again in my sessions, that the superior retina basically corresponds to the inferior fields, and the inferior retina makes the superior field of vision. So whatever is there is basically causing a problem in the inferior retina. Give me a thumbs up if you understand. Okay, so it is giving a problem in the inferior retina. Okay, now what are the differential diagnoses? What are the various things which can cause this? So it can be either a anterior ischemic optic neuropathy. Remember the altitudinal hemifield defects that can be there in the AION. It can be a inferior RD. Remember, inferior RD, superior field loss. It can be a inferior branch retinal artery occlusion. Remember, if it would have been central retinal artery occlusion, if there is a central retinal artery occlusion, there would be a total field loss. Do you all agree? So there would be a total field loss in a central retinal artery occlusion, and a CRVO and a BRVO, they would not present with the field of vision loss. Maximum to maximum, patient would come with lot of floaters complaint, or if there is a macular involvement, there would be slight amount of diminution of vision. There would not be a superior field loss. So these are our diagnosis, various differential diagnosis. So out of that, whatever we have given was a history of RHD or atrial fibrillation. So remember, when we were talking about the central retinal artery occlusion, we told that one of the major cause is the embolus. So these patients are more prone to get the embolus, and this embolus basically can get a obstruction, whether it is a central retinal artery or a branch retinal artery. Okay, so our answer here would be a branch retinal artery occlusion. Do you all get my point? Okay, so this was the snapshot of the notes that we have basically shared, where I have very clearly written that, as you can see, The nasal retina forms the temporal quadrant and vice versa. The superior retina makes an inferior field of vision and vice versa. This shows you that there is a sectoral field loss. And when we were talking about the central retinal artery occlusion, we have specifically written about the role of emboli. So the embolic phenomena is a risk factor for the central retinal artery occlusion as well as branch retinal artery occlusion. Is it clear? Okay, let's move to our next question. So our next question is, which of the following is the most common cause of proptosis in middle age? Can you get my point? Am I audible? Am I audible? Okay, so very good. So the second question was, which of the following is the most common cause of proptosis in middle age? So remember, proptosis, a very important topic, have been asked again and again. And the most common, have you studied the most common list which I have given in our notes? So the most common list, though it is a very very irritating topic, but yes, it has been asked again and again. So always remember what are the various most common causes, and I would just tell you about the ones. You can basically take a screenshot here, and also please remember that if they are asking about the proptosis, the instrument that you use is, can anyone tell me? So the instrument that is used to measure the proptosis is exophthalmometer. Okay, so the most common cause of bilateral proptosis, if they are asking about the children, is neuroblastoma. If that is not in your option, what is the next best option? The next best option is leukemia. If they are asking about the most common cause of unilateral proptosis, remember the word. If they are asking about the unilateral proptosis, then your answer would be orbital cellulitis. Very easy is if they are asking about in the adults, because in the adults, both in the unilateral as well as the bilateral, the answer is the same. What is the answer? The answer is always Graves' ophthalmopathy or thyroid eye disease. Okay, so your answer here would be thyroid eye disease. Okay, so that is basically I would just like to show you a video where in the app I have just told very important what is the question that they are going to ask. So just see this video. Okay, so here as you can see, we are discussing about what are the various important causes of proptosis. Okay, so remember, everything that was asked in the INICET was basically being discussed earlier in the notes and in the app. So any doubt you have, you can just go back and study there. Please remember that it is the basic time where you have to just do a revision for your NEET PG exam. Okay, let's go back to our questions. So the next question was, which is not seen in the oculomotor nerve palsy? What is the nerve? This is the third nerve. So the options were restriction in abduction, dilated pupil, down and out, and ptosis. Which they have asked was, which of the following is not seen? Okay, not seen. Remember these words, not all of the above, because that basically changes your answer. So if they are asking about the third nerve palsy, remember, if there is a third nerve palsy, all the extraocular muscles would be involved except your two muscles that are your lateral rectus and superior oblique. Okay, so the lateral rectus and superior oblique, they are not involved. And what the lateral rectus does is, lateral rectus basically abducts the eye, move the eye out, and the superior oblique would move the eye down. So there is a down and out position. So the patient would be able to do the abduction. Abduction is out, but he would not be able to do the adduction. Okay, so your answer is very clear here. Restriction in abduction have been told again and again in the nerve palsy section. Okay, so this is the 9 gaze which they can ask again, and they would just give you the 9 gaze and would ask about the diagnosis. So as you can see here, there is a ptosis. Why there is a ptosis? Because there is a LPS involvement. Okay, and as you can see, this eye is just going a bit out, otherwise there is not much movement of this eye. Okay, so there is a partial ophthalmoplegia. Do you all agree? There would be a partial ophthalmoplegia in these cases, and the eye would be down and out, and definitely there would be ptosis because of the LPS involvement. Is it clear? Okay, this was I will just show you the video where we have discussed about the third nerve palsy. As you can see here, so this was the section of third nerve palsy which we have taken in our app, and very clearly we have told what are the various parameters, what are the things, clinical features which you would get when you get a third nerve palsy straight from the app. Okay, let's move to our next question. Which of the following is not an action of superior oblique? So we have got one question from neuro-ophthalmology, one question from retina, and one question from squint. Now, superior oblique, we all know, is basically an entorter. And the second reaction is that it is a depressor and an abductor. Remember, it is not doing adduction. Okay, so the answer here would be very clearly D. Is it clear? So superior oblique is not a adductor, and this was something which was asked directly from this table which was given in our notes and have been explained in our videos as well. Okay, so this was something which is a screenshot which I have taken from our notes, exactly asking about what was the question in your exams. Okay, let's move to our next question. The next question was, which of the following is the definition of anisometropia? Okay, another one-liner, another very easy question, another one question directly from the app. So remember, whenever they are asking about anisometropia, this means they are asking about there is a difference of refractive error of the both eyes. So my answer here is very clear. It is difference of the refractive error of both the eyes. And again, the question straight from the app. Remember these three terms when they are asking about the anisoconia. It is the difference in the size of images that were perceived. If they are asking about anisometropia, there is a difference of refractive power of the eye. And if they are asking about the anisocoria, this is the difference in the size of pupil of the eye. Is it clear, everyone? Okay, let's move to our next. Okay, so this was something, another question straight from our notes, straight from our app, and this is the screenshot which I have basically put it here, showing you the very important topic in optics. Within 2 hours you can revise this topic of optics and get whatever you want to know in your upcoming exam. Okay, with this we move to our next question. There was a question which was my favorite question of this one, and where they have asked about an 80-year-old man presented with the glaucoma or high intraocular pressure. Very important is patient was having a dense white cataract with a deep anterior chamber. Okay, which of the following would be the most possible diagnosis here? Very important thing that they have given here is the person was having a deep anterior chamber. So now when they are asking about deep anterior chamber, your phacolytic glaucoma, this is just gone. So your options are these three. Remember, in Fuchs dystrophy, or some students were saying it was in the option Fuchs heterochromic iridocyclitis. That cannot be the answer here. Remember, this is usually seen in young adults. Okay, and these patients who are having Fuchs, they do not have a dense white cataract, they have a mild grade of uveitis and high IOP. So this is not the answer. Neovascular glaucoma, you would not have this type of feature, you would not have dense white cataract. What you would be having would be neovascularization of iris, which is also called rubeosis iridis. Do you all agree? So that is not your answer here. Okay, so whatever is left is my answer of choice, which is phacolytic glaucoma. Okay, directly a question from our notes. And remember, they are asking about a dense white cataract and deep anterior chamber. It is always a phacolytic glaucoma. And what hypermature cataract does is, in the hypermature cataract, you would have micropores in the capsule. Through the micropores in the capsule, the various lens antigens, they come into the anterior chamber and does the inflammation. So that causes a high intraocular pressure with a deep anterior chamber, and that basically goes to your diagnosis of phacolytic glaucoma. Phaco means cataract, okay, lens, lytic means there is a lysis, glaucoma means high intraocular pressure, goes to your diagnosis of phacolytic glaucoma. And as I would just show you again the question straight from the app. As you can see here, so you can see that there is a question phacolytic glaucoma which we are talking about, and that was the directly the question that was being asked, and where I have very clearly told about there is a deep anterior chamber. See, I am writing deep anterior chamber, cells plus flare. So some students were saying that there were cells plus flare, that was also in the option. So you can see directly from the video, we have exactly told what was being asked in your exam. Okay, okay, let's move to our next question. So next question was another question straight from the app. So proud of you. A construction worker presented with the history of tuna falling in the eye. So tuna falling in the eye, they are asking about what? They are asking about the chemical injury to the eye. And then they are asking what is the first step. So remember, whenever there is a foreign body and if it is a tuna particle, okay, there is an alkali injury, it is the most dangerous type of chemical injury to the eyeball. And first thing is, you just avert the eyelids, remove the tuna particle and do a copious irrigation. Whether you do this irrigation with normal saline, and if it is not available, do with the water, but a 30-minute irrigation is so important after double eversion of the eyelid to just remove any tuna particle which is there anywhere in the eye. So the answer here would be copious saline irrigation. First thing to be done whenever you see a patient who is having a chemical injury. Very good, Dr. Ramya. Now you can see this question was asked again directly from our videos, directly from our notes. See, so why it is important to study the notes is that first, the notes should be something which you can understand. So all these notes have been basically been written, it's not something which is typed, so something which you can understand easily. And first thing I would basically like to show you is the what is I have written: thorough washing of the eye with saline or water for at least 30 minutes. This was the first thing I have written in the notes, and you have got as the question. So happy for you, all of you. So I think most of our students would get 11 out of 11 or 12 out of 12 in ophthalmology. So the next question was again a question which was a previous year question. A patient with having a cornea with diminished sensations. When there is a diminished sensations, what is the organism that you basically feel? The organism would be leprosy. Okay, so remember, a leprosy has been asked earlier also. There are a lot of ocular manifestations of the leprosy. Please go to the section of, if you have not basically subscribed for the app, you would have a 3-day trial period also. And I would request you go to my systemic ophthalmology section. Every year for last 5 years, there was not even a single year they have not asked anything from the systemic ophthalmology. So see the systemic ophthalmology, ocular manifestations of the microbes, and you can see that there are a lot of ocular manifestations of the leprosy. And the first thing is that these patients have a thickening and bleeding of corneal nerves and the corneal anesthesia. These patients can also have interstitial keratitis, conjunctivitis, erythema nodosa leprosum. One more point I would like you to basically remember is that sometimes iris pearls are seen, and iris pearls are also seen because of the Mycobacterium leprae, and they can have also a lot of lid manifestations. The most important one of them is madarosis and leg ophthalmos. So these are some important points you should remember regarding the leprosy. And again, I would just show you the video through which they have basically asked this question. Okay, just see. So this was the leprosy part. Okay, as you first thing what I have written here. Yes, Kawaljit, that I have just shown you in the explanation, leg ophthalmos. So see, corneal anesthesia, that was the first thing that I told you when I was basically showing you the leprosy and its manifestations. Okay, very, very important is whenever you basically see a question, you try to answer it. And in the NEET PG, I would recommend you to basically answer maximum number of questions. Okay, so very good, Dr. Kawaljit, and I hope you would get a very good rank. So proud of you. Okay, so next question to you is, a 40-year-old patient presented with the sudden onset of flashes in the field of vision. Here he is wearing thick myopic glasses. So what they are asking about, a sudden onset of flashes. Onset of flashes, very important clinical feature of retinal detachment. So my answer here is retinal detachment. And for making this question easier, they have given a lot of hints. So they have told that yes, there are sudden onset of flashes, and he is wearing thick myopic glasses. So a high myopia, what happens in a high myopia? The retina is thin, so there are more chances of getting retinal tears and holes, and that would basically cause a retinal detachment. Remember, a subarachnoid hemorrhage can basically have some retinal hemorrhages. Central serous retinopathy, patient would come with the central blurring of vision. Same with the cystoid macular edema. None of these would have a sudden onset of flashes. Very, very important. A curtain falling in front of the eye and the flashes. These are very, very important specific features for the retinal detachment, Dr. Kaval. Okay, so I just show you another screenshot from our notes. Very, very important. I have written here is flashes. As you can see, concise, and what you need to know, flashes are very important whenever we are talking about the retinal detachment. And see, high myopia, if you can see here, so proud of you that this high myopia, so great that everything has been asked in the concise notes. Okay, so what was the next question? Next question was something which I differ with some of my colleagues as the answer, and I have a very important reason and proof why basically I tell you. So this question have been asked in various dimensions, have been written in various types in various apps, but what I want you to focus is that a 2-month-old child presented with photophobia and hyperlacrimation, and what they have asked was, which of the following is not the cause? Any one of you? Okay, so it was, I just changed so it is entropion according to Dr. Kavaljit. Okay, so it was entropion. Okay, so which of the following is not the cause? What would you basically try to answer here? What is your opinion? So first of all, whenever we see a 2-month-old child, okay, think if there is a photophobia, first thing that comes into my mind is glaucoma. Okay, so these patients who are having congenital glaucoma, they have this typical feature of large eyeball plus photophobia plus hyperlacrimation. So definitely glaucoma is something which can cause both of them. So I would write yes, yes. Now entropion. So when we talk about the entropion, entropion can basically cause the inversion of the eyelids, and that can basically cause trichiasis. Do you all agree? If you agree, just give me a thumbs up, please. So this can basically, the eyelashes can there touch the cornea, and when they touch the cornea gets irritated, and what it basically causes is that it would cause some corneal ulcers or epithelial defect. Whenever there is an ulcer or epithelial defect, it is usually having a lot of photophobia. So these patients definitely would have hyperlacrimation and photophobia, but no ophthalmos. In congenital glaucoma, there would be a large eyeball as well. That would not be there in the patients who are having a entropion. Now, dystichiasis. There was a slight confusion here. Dystichiasis, I told you, was having a lot of eyelashes. There are more than a single row of eyelashes. Okay, so this is my eyes. So we have 3-4 layer of eyelashes. So if we have more layer of eyelashes, definitely it can touch the cornea as well. So what I see is that yes, though rarely, but this can basically cause a photophobia and hyperlacrimation if it touches the cornea. Do you all agree? Okay, now some faculty says that congenital nasolacrimal duct obstruction, this can also cause a photophobia and hyperlacrimation, but my answer here is no. A nasolacrimal duct obstruction, the patient, I have seen so many patients of NLDO, we have done so much syringing in our RP center AIMS and as well as in our private practice. These patients, the parents come and say that there is continuous watering and discharge. So definitely there would be hyperlacrimation, but I am very confident to tell you that these patients are not having photophobia. Okay, so my answer here of choice is congenital nasolacrimal duct obstruction. So D is a better answer than C. So remember, whenever you are there doing your MCQs and you are appearing for your NEET PG as well as INICET exam, sometimes more than one answer can be correct. You have to mark which one is the best. And now you would say, sir, why not dystichiasis? Dystichiasis would not cause a photophobia and hyperlacrimation. Now I have this article for you. Article straight seen from British Medical Journal, and if you can see this article, they have written very clearly that these patients are having, as you can see, marked photophobia. Can you see this? So there was a marked photophobia. So my answer here would be NLDO, which does not cause the photophobia, and C can be the answer. Do you all agree? Okay, so the next question was regarding the retinitis pigmentosa. Again, straight from the notes. Which of the following statement is not true regarding the figure given below? See the figure. Very easily you can see in this figure what is happening is that there is a waxy pallor. Okay, there is attenuated vessels and there is pigmentation all around. Okay, so this patient is having a retinitis pigmentosa. I don't think that there would be any confusion here. So whenever we are talking about the retinitis pigmentosa in the electroretinogram, I told you that both the A wave and B wave would be flattened. There would be a flattened ERG. Now let's see the other options. In late stages, patient present with the nyctalopia. Now this is a wrong statement. Remember, they have asked about which of the following is not true. Remember, it is not in the late, it is the early stages the patient presents with the nyctalopia. So both rods and cones are involved. Definitely it's a rod dystrophy, but later on your cones would also be involved. So this is rods followed by the cone dystrophy. And in late stages, definitely there is a loss of peripheral vision also. So initially patient would have a mid peripheral field loss, and in later stages you would have even a tunnel vision. So we see that and call that ring scotomas. Do you all agree with me? These are the ring scotomas, and just showing you the retinitis pigmentosa notes. Okay, so as you can see, we have written chief complaint as the nyctalopia. Chief complaint is the first complaint which the patient comes. Very specifically written here, night blindness. It is not the late manifestation of the patient. Is it clear? Okay, chalo. So these were the various questions that have been asked in your exam, and I think we have dealt with all of them. If there is any doubt in any of the questions, you can just put it here and you can just ask us in any of the groups. And remember, please do a rapid revision for your NEET PG exam. And thank you very much for attending this session. All the best. God bless.